Boa noite a todos, mais uma vez, obrigado pela vossa presença. Estamos aqui hoje para mais uma sessão das nossas Prostate Cancer Talks. Hoje vamos falar do carcinoma da próstata metastático hormonossensível. Eu vou falar um bocadinho em inglês agora. So it's my pleasure to introduce you to Dr. Anna Goldberg. Dr. Anna Goldberg is a distinguished urologist nowadays in New York, USA. So he's a urologist that did his residency in Israel and in Tel Aviv University. Later, he completed his SUO, Uro-Oncology Fellowship at the Princess Margaret Cancer Center at the University of Toronto. During this fellowship, he completed his Master's of Science in Clinical Epidemiology, also at the University of Toronto. And as I said before, he's currently an assistant professor of urology at UPSTATE Medical University in Syracuse, New York. So he's mainly interested in research in cancer, prostate cancer, and upper tract urothelial carcinoma. So thank you, Hanan, for joining us. It's a pleasure having you. So as moderators, we have today as well a distinguished oncologist, Dr. António Quintela from Hospital de Santa Maria in CUF Descobertas. We also have a urologist from IPO Porto, Dr. Isaac Braga, and also from CUF Porto. So Hanan, the floor is yours. Thank you very much.
Yes, thank you. Thank you very much, Ricardo. Thank you very much for having me here. It's a real honor and pleasure to present, and hopefully I can learn from you guys as much as you can learn from me. And we'll start. So I have no disclosures. We're going to talk a little bit about metastatic hormone-sensitive prostate cancer, a little bit of background. I'm sure everyone knows this. Most common prostate cancer is the most common non-cutaneous malignancy in the US, second most common cause of cancer-specific death. In 2019, we had more than 174,000 cases here and more than 30,000 deaths each year. That's pretty much a stable number. I managed to find this about Portugal. I don't know if this is updated or not, but more than 5,000 cases each year, 22.4% of overall cancer cases, the mortality rate of 3%. So it's pretty much similar to the US and Western countries. And of course, localized prostate cancer is the most commonly diagnosed disease, but the incidence of de novo metastatic disease is growing quite rapidly. This could be a result of decreased PSA screening, as you might all know, of course, from the US task force in 2012, which pretty much happened in other countries, in the Western countries as well. Later on, it was changed from a grade D to a grade C recommendation in 2018, but that definitely decreased prostate cancer screening. We know that many prostate cancer patients who have localized disease will later recur and develop metastatic disease. Metastatic disease occurs in approximately 1/3 of prostate cancer patients, usually to the bones, lymph nodes later on, liver, thorax, and about almost 20% having multiple metastatic sites. The overall survival, cancer-specific survival, sorry, for the localized disease is excellent, as you all know, close to 100%. But when you have metastatic disease, that's a completely different story. And these are the patients we are all trying to treat and save. Conventional treatment of metastatic hormone-sensitive prostate cancer has always been, at least for the last 40, 50 years, androgen deprivation therapy, ADT. Prostate cancer metastases are usually in the beginning hormone-sensitive. That's why it's called that way. The hormonal treatment achieves the castrate levels of testosterone with either bilateral or orchiectomy, or by the use of ADT. Eventually, the hormone-sensitive state transition to a castrate-resistant prostate cancer, usually defined by disease progression despite ADT with castrate testosterone levels. It may present either as a continuous PSA rise or disease progression or appearance of new metastasis. And CRPC is a bad disease, as you all know. It's a median survival of 3 years, maybe a little bit better now with all the new treatments. and it, of course, is associated with a deterioration of quality of life. This is just a simple schematic of hormonal treatment where it works, where the surgical castration works on the testicles, of course, where the LH-RH analogs work from the pituitary to the testis. This is something I'm sure everyone knows. There have been some approaches to improve the response rate to ADT and improve side effects. This has been, this includes intermittent hormonal therapy, adding an anti-androgen, but the benefit of these approaches has resulted in a very modest improvement rate of only about 2 to 3% in 5-year survival rate. And then we can have a whole discussion just about this thing, and then I just wanted to mention this, but we'll not focus on this. There has been a lot of new treatments in the last few years, especially in the last, since 2015. These are mainly treatments that have been previously used in metastatic castrate-resistant prostate cancer and have now been moved earlier in the disease to non-metastatic and to the hormone-sensitive prostate cancer space. There have been several landmark studies, a lot of publications in the New England Journal of Medicine. We'll go over all of them briefly, but it's really an evolving space, and really the advance that medical science has managed to do in this field is actually quite extraordinary. So we'll start with chemotherapy. So earlier studies that were done with chemotherapy in metastatic prostate cancer combined with ADT actually were not so promising. This was partly due to the toxicity and lack of really sufficient active agents. The agents that were tested were ketoconazole, doxorubicin, vinblastine, and others. They did not confer a significant overall survival advantage, and about 51% of patients experienced significant adverse events. Other assessed medications simply did not show any kind of benefit. Mitomycin, cyclophosphamide, a lot of studies were done on this. And only in 2004, after the TAX 327 study in New England Journal of Medicine was published, basically showed that docetaxel has improved survival in castrate-resistant prostate cancer patients. And then it was incorporated into that treatment. So this is a landmark study, which I'm sure you are all aware of. As I said, docetaxel was the first agent to demonstrate a survival benefit in hormone-sensitive prostate cancer. But again, not all trials at the beginning showed a benefit of this drug. The famous landmark study, also the French GETOG AFO15 trial, which enrolled close to 400 men with metastatic hormone-sensitive prostate cancer and randomized them to either ADT alone or ADT in combination with docetaxel. So again, over a median follow-up of close to 83 months, no survival benefit was shown here. But some post-hoc analysis of this study did suggest a trend toward a survival benefit in men with high burden disease. This is the GETOG 15 study published in Lancet. And then we come to the CHAARTED study, which is the biggest study in this specific drug, New England Journal of Medicine paper. First author was Christopher Sweeney. This was the first trial showing an improved overall survival of close to 14 months with the use of docetaxel in metastatic hormone-sensitive prostate cancer patients. There was also an overall survival benefit in the pre-planned subgroup analysis with a hazard ratio of 0.6 in men with high burden metastatic disease. And this was defined as presence of either visceral metastasis or more than 4 bone lesions with at least 1 bone lesion beyond the axial skeleton. And that's pretty much the definition that most are using today for high burden disease. There are other definitions, of course, which we'll talk about. These findings were validated in the longer median follow-up of this study of almost 54 months. The benefit was consistent across all subgroups with 2 notable exceptions. So patients with a low disease burden did not have a significant hazard ratio, 1.04. And patients who had prior local therapy also did not show any significant benefit as well. This was the CHAARTED study. This was the study design. As I said, there's long-term follow-up of this showing that the benefit still remains in high-burden disease. Later on, the arm C of the famous STAMPEDE trial, which is still ongoing, of course, with many new arms being added all the time. Again, what the British have done here is quite amazing. And in this specific arm, they compared 6 cycles of docetaxel to standard ADT in men, again, with metastatic hormone-sensitive prostate cancer or locally advanced disease. And again, chemotherapy conferred a median overall survival of 10 months, has a ratio of 0.78. They also tested zoledronic acid alone, and this did not show any overall survival benefit. There was a large meta-analysis validating the role of early docetaxel for metastatic hormone-sensitive prostate cancer, and included this trial as well. This was the STAMPEDE Arm C trial, and the 4 different arms with the standard of care with zoledronic acid, standard of care with docetaxel, and standard of care with both zoledronic acid and docetaxel. The quality of life, of course, as expected, decreased after 3 months of chemotherapy compared to ADT alone. And both the GETUC and the CHAARTED study demonstrated that the most common grade 3 and above adverse events included neutropenia, febrile neutropenia, fatigue, and these were the main ones. In the STAMPEDE trial, the main adverse events rates, the rate of the main adverse events rates were 52% compared to 32%. But they did show that after 12 months, this had improved to approximately 10% of grade 3 adverse events in both arms. So that is something that we need to consider, of course, the adverse events with chemotherapy, and we will talk about this later. We then move on to another great finding, the ABIRATERONE drug in 2017. It's an anti-androgen medication, was also assessed specifically in this disease space of metastatic hormone-sensitive prostate cancer after it was assessed in castrate-resistant prostate cancer and found to be beneficial. ABIRATERONE inhibits the CYP17A1 enzyme, which is basically manifested as 2 enzymes, the 17-alpha hydroxylase and the 17-20-lase that are expressed in the testicular, adrenal, and prostatic tumor tissues. You can see them here in this diagram. The CYP17A1 catalyzes 2 sequential reactions. One is the conversion of pregnenolone and progesterone to their 17-alpha hydroxy derivatives. And the other one is the formation of DHEA and androstenedione. So you can see it exactly what it affects and what is basically caused by adding this drug. Approval of this drug in the pre-chemotherapy and post-chemotherapy era before led to its application in the earliest stages of disease of metastatic hormone-sensitive prostate cancer. And the Arm G of the STAMPEDE trial specifically analyzed this combination of abiraterone and 5 milligrams of prednisolone with ADT in HSPC patients. Median follow-up was 40 months, and the abiraterone arm conferred almost a 40% relative overall survival improvement when compared to ADT alone, which is quite impressive, with a hazard ratio of 0.63. Additionally, the abiraterone arm showed a 71% improvement in failure-free survival. It also decreased skeletal-related events, and specifically in the M1 cohort, the hazard ratio was quite significant, 0.45. This is the LATITUDE study, the STAMPEDE study that was published. As you can see, the overall benefit, I'm hoping you can see this, is statistically significant in favor of the combination therapy with abiraterone, and this was across the board, and this was quite impressive. We move on to the LATITUDE trial, which is the second abiraterone trial published in 2017. This was a very big study, multinational, 235 sites, 34 countries, high-risk HSPC patients, and again, assessing the role of the combination of abiraterone, prednisone, and ADT compared to ADT alone. Median follow-up was 30 months, and overall survival advantage was shown to be 17% in the abiraterone arm, with a hazard ratio almost identical to one in STAMPEDE, with 66% versus 49%, with hazard ratio of 0.62, which is quite remarkable. Based on these results, ABIRATERONE received FDA approval very close to the publication dates in February 2018 for the treatment of high-risk hormone-sensitive prostate cancer patients, expanding its indication beyond these CRPC patients. Both STAMPEDE and LATITUDE trials also showed benefit in radiologic-free PSA progression and prostate cancer-specific mortality. So there's absolutely no doubt that these drugs are beneficial. This is the LATITUDE publication and study design. The post-hoc analysis of LATITUDE demonstrated that ABIRATERONE was beneficial in both groups of patients with high and low burden metastatic disease, has a ratio of 0.66 and 0.54. The LATITUDE trial presented patient-reported outcomes as well, showing improvement in time until pain progression, longer time to worsen fatigue intensity, longer time to deterioration of functional status, and there were no significant safety and toxicity issues more than what was known for the CRPC trials. Extended follow-up at the GEO-ASCO in 2019, and I attended that meeting. The final analysis of the LATITUDE trial was shown, median follow-up of more than 50 months. There were 618 deaths, and about a quarter of the patients remained on ABIRATERONE. ABIRATERONE continued to show median overall survival benefit over placebo, 53 versus 36 months, with a hazard ratio of 0.7, so the benefit is stable over time. Secondary endpoint analysis, ABIRATERONE outperformed placebo in all the categories that were tested: pain progression, skeletal-related events, chemotherapy and subsequent therapy initiation. And patients with a high burden disease, based on the CHAARTED criteria, derived the most benefit. Their hazard ratio was 0.62. When compared to the low burden disease, which also had a benefit, but it was a little bit lower, it was 0.72. But this was not statistically significant. The adverse events reported, about almost 22% of patients had hypertension, 12% hypokalemia, 9% hepatotoxicity, and 4% cardiac disorder. These are the side effects that you can see from the ABIRATERONE on the website. It's gone generic now, but these are the side effects. This is what I tell patients, what to expect, what are the most common side effects, and what are the serious side effects that they should watch out for. I'm sure everyone knows this, but this is something always important to mention to patients before and know what you're heading into. Let's move on to, just for time's sake, to enzalutamide. This is a selective non-steroidal androgen receptor antagonist that had shown overall survival benefit also in CRPC, very similar to ABIRATERONE. It acts as a selective antagonist, silent antagonist to the androgen receptor. And unlike the first generation non-steroidal anti-androgens, enzalutamide does not promote translocation of the AR to the cell nucleus, and it also prevents binding of the androgen receptor to DNA. So it basically works on three separate areas. It inhibits the binding to androgen receptor, it inhibits the nuclear translocation of the androgen receptor, and it also stops the binding to DNA itself. We'll talk about some of the trials of the enzalutamide. The first one is the ARCHES trial. This was published in 2019. Total of 1,150 patients who were randomized to treatment with either ADT alone or ADT plus enzalutamide. Patients were stratified by disease volume and prior chemotherapy. Approximately 18% of patients in each arm received treatment with chemotherapy. This was the study design and publication. Excuse me. As you can see, as I said before, enzalutamide plus ADT versus placebo and ADT. The risk of radiographic progression or death was significantly reduced with enzalutamide compared to placebo. The median was not reached for enzalutamide, and it was 19 months for the placebo. Hazard ratio was quite astounding, 0.39. Enzalutamide significantly reduced risk of PSA progression, initiation of new anti-neoplastic therapy, SRE, CRPC, and pain progression. There was similar impressive improvements were noted in all the pre-specified subgroups analysis that they did by disease volume and prior chemotherapy. The overall survival data were still immature at the time of publication because they only had 84 deaths. And basically patients in both arms had a very high quality of life that was maintained over time. The rate of grade 3 adverse events or worse was almost 25% in the enzalutamide arm, and very similar to that of the placebo arm, so no difference there. These are the Kaplan-Meier curves that were shown. This is for radiographic progression-free survival, clear advantage to enzalutamide. This is needing antineoplastic therapy, PSA progression, and symptomatic skeletal related event, as you can see. There was some post-hoc analysis for this as well. And this demonstrated that the greatest benefit was seen for patients with nodal disease, and much less benefit was seen for patients with visceral disease. Another you can see this in the graph. This is each line shows different types of metastasis. The orange is the lymph node metastasis, which conferred the best outcome, and the blue is the visceral and bone plus lymph nodes, which had the worst outcome. The second post-hoc analysis assessed the efficacy of enzalutamide according to baseline PSA levels, and basically they showed there was no difference with outcomes with regard to the patient's PSA levels. The next trial is the ENZAMET trial, another New England Journal of Medicine publication. It's a phase 3 randomized controlled trial, 1,125 patients receiving ADT plus minus chemotherapy and randomized to treatment with enzalutamide or with a non-steroidal anti-androgen. ENZAMET is the first hormone-sensitive prostate cancer trial to report overall survival data of outcomes of enzalutamide plus ADT in patients who were previously treated with chemotherapy. They did a lot of analysis here, randomizing patients by disease volume, planned early chemotherapy, planned anti-resorptive therapy, comorbidity score, and study site. 53% of the patients in the non-steroidal anti-androgen arm had a high burden metastatic disease, and also about 52% of the patients in the enzalutamide arm. This is the publication and the study design. And again, the results were quite significant. Overall survival significantly improved in the enzalutamide arm, hazard ratio of 0.67. All the secondary endpoints, time to PSA rise, clinical progression, and death and time to clinical progression were all improved with a very significant hazard ratio. The pre-specified subgroup analysis based on receipt of chemotherapy, enzalutamide significantly improved the time to clinical progression, but did not improve overall survival among men who previously received docetaxel. However, in men who did not receive chemotherapy, enzalutamide did show improved clinical progression and overall survival. So that's an important difference to remember, so that patients who were previously treated with chemotherapy did not show an overall survival benefit with enzalutamide compared to patients who were not previously treated with chemotherapy. Serious adverse events occurred in about 42% of patients, and greatest toxicity was shown in the addition of enzalutamide as expected, and patients who were also treated with chemotherapy as expected also had more related adverse events. This is the comparison of enzalutamide to the non-steroidal anti-androgen in patients who did receive chemotherapy in the first line, and these are patients who did not receive previous chemotherapy. So these 71% of them had high volume disease, and here 37% had high volume disease. And as you can see, in patients who received chemotherapy, there was significant difference in clinical progression-free survival, but no difference in the overall survival. But in patients who did not receive chemotherapy, there was a significant difference in the overall survival in patients who received enzalutamide. These, again, I hope you can see this. This is from the ENZAMET trial. The left is everything in favor of enzalutamide. I just marked the things that did not show a benefit to enzalutamide. So again, as I previously said, patients who were treated with chemotherapy, there was no significant benefit that was shown. Anti-resorptive therapy did not show that. And patient with visceral metastasis also did not show any significant difference in favor of enzalutamide. This is again from the enzalutamide website. What are the common side effects? What I tell patients, I have quite a few patients that I give them enzalutamide. The common ones, again, you always worried about CNS disturbances, seizures, and other encephalopathies and things like that. That's usually a contraindication not to give them enzalutamide. Allergic reactions, of course, heart disease, falls and fractures. I have not seen that too much. I don't know. It's interesting to hear your experience, but it's definitely something that is considered something that people see. The common side effects, weakness, fatigue, back pain, hot flashes, constipation, high blood pressure. I think that's pretty common. You do get to see a lot of those. Let's move to the third drug. The fourth drug, actually, apalutamide. Again, another oral non-steroidal anti-androgen, which works very similar to enzalutamide, same mechanism. It has shown benefit over placebo in the non-metastatic CRPC setting in the Spartan phase 3 placebo-controlled trial. In 2019, the Titan study was published, and this is an international phase 3 trial randomizing, again, metastatic hormone-sensitive patients to treatment with ADT plus or minus apalutamide. About 11% of patients had prior chemotherapy, and most patients, 63%, had high volume metastatic disease. Again, New England Journal publication. This is a study design. Median radiographic progression-free survival was 22 months in the placebo group and was not reached in the apalutamide group. Apalutamide also improved the overall survival, hazard ratio of 0.67, 33% reduction in risk of death. Median overall survival had not yet been reached. The overall survival benefit was also consistent throughout all the subgroups. And after 2 years of follow-up, there was a 20% difference in the radiographic progression-free survival rate, with almost 70% of patients in the apalutamide arm being free of progression. The secondary and exploratory endpoints also favored this new drug, apalutamide, with 75% of patients remaining free from PSA progression in 2 years with the drug. Only 8% discontinued the drug due to adverse events, and these were usually a grade 1 or 2 rash, occurring in about 40% of patients. These are the side effects that they published in their Titan study. Rash, fatigue, hot flashes, hypertension, arthralgia, these are the common ones. And the grade 3 and 4 adverse events, again, hypertension, rash, and fatigue were the main ones. So, trying to summarize the data, we have many New England Journal publications here. So, anyone who wants to do a randomized trial in prostate cancer has a very good chance of getting a publication in New England Journal of Medicine. Ricardo, this is for you. Many trials, chemotherapy, abiraterone, enzalutamide, apalutamide, a lot of progression in the last 5 years, many new drugs to add. This is a summary table that I did trying to summarize basically the results of these trials and the patients that were assessed in these trials, median overall survival, and the hazard ratio. This is quite impressive. Whatever you choose, whatever drug you give, the overall survival advantage, the progression-free survival with the hazard ratio, quite impressive. So this is something that it's always good to have. So which treatment for which patient? That's something that I always ask, and I can never get a good answer. I don't know the answer, to tell you the truth. I've asked this many people, many urologists, many oncologists. I don't think we have good guidelines at the moment. I think there's some basic rules that we can follow, but I think we just need more studies, because you have to remember none of these medications have been studied head to head. So we don't really know which one is better for which. If you look at the guidelines, so this is the NCCN guidelines, that's what here in the US we all look to. So basically, look at the treatment for hormone-sensitive prostate cancer, everything's there. They don't state which one is better, which one is preferred. Give whatever you think you want to give. What we call physician discretion. So that really doesn't help too much. And then if you look at the European guidelines, so again, this is very similar they say that for offer ADT combined with chemotherapy to patients with first presentation is M1 disease, and then that's strong. And later they also say you can offer abiraterone or apalutamide or enzalutamide to all the patients. So this is pretty much the same as the NCCN guidelines. Basically, every choice is good. So no prospective comparison trial has been published. In the STAMPEDE trial, there was a period of simultaneous enrollment in Arm C with the chemotherapy and Arm G with abiraterone, and a post-hoc analysis compared outcomes between these two arms was reported. So basically a comparison between abiraterone and chemotherapy. So in this comparison, abiraterone was associated with a longer failure-free survival and progression-free survival, but no significant difference was shown between these arms in terms of symptomatic skeletal-related events, overall survival, or prostate cancer-specific mortality. So basically, both drugs have very similar results. The recently published network meta-analysis indirectly compared ADT plus docetaxel versus ADT plus abiraterone by using a common comparator arm. Chris Wallace, who is a resident, and was a resident, he's now a fellow at Vanderbilt University, published this. He used data from the GETUC trial, the CHAARTED, the LATITUDE, and the STAMPEDE trials. More than 6,000 patients analyzed, and almost 20% received chemotherapy plus ADT. A quarter of the patients received ADT with abiraterone, and 55% of patients received ADT alone. The pooled hazard ratio for overall survival demonstrated a benefit for chemotherapy and abiraterone when compared to ADT alone, but there was no statistically significant overall survival difference between both these arms. So again, pretty much similar. Both therapeutic options are probably acceptable in this hormone-sensitive prostate cancer space. So some practical considerations, something that I managed to ask people. This is not written anywhere. Currently, there's no guidelines, but that's what I heard smarter people than me do, so I try to copy them. So chemotherapy can be offered to hormone-sensitive prostate cancer patients who are eligible for chemotherapy, especially if they have a high-burden disease. So there's a notion that you should try to give them the chemotherapy. If the patient comes with a very high-burden disease, that's usually the first drug that he should receive, especially if he's fit, he's able, he doesn't have too many comorbidities. It should not be given to patients with advanced age, poor performance status, significant comorbidities, and of course, if the patient doesn't want chemotherapy. Abiraterone does have a better side effect than chemotherapy. It's much easier to administer, it's just a pill. Only 12% of patients discontinuing this therapy due to toxic effects, and only 12% needing dose modification. The treatment duration with abiraterone is longer, of course. Chemotherapy is usually just 6 cycles. This, of course, raises potential safety concerns, especially in patients with pre-existing risk factor for cardiovascular disease. And as I said previously, chemotherapy is preferred in patients with good performance status, avoid the feared long-term effects of steroids that come with abiraterone, and the adverse effects that come with this, like hyperglycemia, cardiovascular risks, osteopenia, and others. The mandatory need for concurrent prednisone with abiraterone can potentially, of course, limit its use in patients with unstable diabetes or unbalanced diabetes, chronic gastric ulcers, and any existing infection. There's no good data currently to make any recommendation on when it's preferable to give enzalutamide or apalutamide, the newer drugs here. It should be avoided, as I said previously, in men with any kind of central neurovascular disorders, and especially people with seizure disorders. Okay, and this is a small table just emphasizing the main toxicities, the need for chemotherapy, and what is probably the best setting, as I said before, for chemotherapy, high volume disease. A little bit about cost. Again, I don't know how it is in Portugal, but here in America, it's of course a huge issue. Now abiraterone has become generic, so it has, of course, the price is much lower, but 6-cycle docetaxel course is approximately $20,000. And this is data before abiraterone became generic, and then you can see the total drug cost of abiraterone and enzalutamide, and this is for an 18 months period. So these are expensive drugs, and here in the States, when I give the drugs, it's a significant issue. You have to remember that all these cost analyses were done in the CRPC setting. So this is not MHSPC, which is a little bit different, and that's something to remember. Apalutamide, we don't have data yet, at least not that I know of. Patients with low burden metastatic disease or significant comorbidities, you have to remember that ADT alone is still a viable option. If it's very, less than one metastatic site or a few metastatic sites, and the patient is a very sick patient, and you're very worried about adverse effects, then giving him only ADT is still in the guidelines, both American and European. So that's always an option to remember. Now, I know Dr. Chandrasekhar gave a whole talk about oligometastatic disease, and I'm sure he also mentioned the treating of the primary tumor. But I think it's important just to touch on this because this is something very relevant to us urologists, whether we need to treat the prostate itself in these patients when we see them de novo, because I'm faced with this challenge all the time. So there's that data suggesting that primary tumor in prostate cancer plays a substantial role in disease progression, even and despite the development of metastatic disease. Most likely mechanism behind the outcome benefit for this is the reduction of tumor burden. Also, specifically for radiation combined with ADT, there's a synergistic effect resulting in double-strand DNA breaks in cancer cells with the result of apoptosis, abscopal effect, and all that. We'll not go into that too much. There's also an immunomodulatory effect of this combination. There's been some prospective studies specifically for radiation, the HORAD trial, which randomized patients to ADT alone or ADT plus ERBT to the prostate. This trial was a negative trial. There was no differences in the overall survival, but the median time to PSA progression was significantly better in the arm that received radiotherapy. And then we have the STAMPEDE trial, which we all use as an example that we should treat the prostate in metastatic patients. This trial evaluated more than 2,000 patients and randomized to ADT alone or ADT plus radiotherapy to the prostate, and the radiotherapy to the primary tumor did not improve overall survival when they took all patients into account. But when they did the subgroup analysis in the low volume subgroup, 819 patients, there was significant overall survival benefit when adding radiotherapy to the prostate. In a recent systematic review and meta-analysis, the stopgap, there was no evidence that adding prostate radiotherapy to ADT improved survival in unselected patients, but there was a clear difference in the effect of metastatic burden on survival. And in patients with low metastatic burden, there was an absolute improvement of 7% in 3 years, which is quite significant. So these data, again, suggesting that for low burden disease, oligometastatic disease, treating the primary, at least with radiation, is probably not a wrong thing to do. What about surgery? We're all interested in that. So of course, there's still no prospective studies, There are several retrospective studies, including population-level studies, showing that surgery in oligometastatic patients can cause improvement in several outcomes, including delay in CRPC, progression-free survival, cancer-specific survival, and overall survival. These studies also support the role of pelvic lymph node dissection for these patients. There are many studies currently assessing the role of surgery in the primary tumor. We're not going to go over all of them. I think there's a few important ones here. The SWOG is the American trial led by Brian Chaplin, randomized phase 3 trial, enrolling more than 1,200 patients assigned to receive either standard systemic therapy or standard systemic therapy plus either surgery or radiation to the prostate. There's a large, the PEACE-1 trial is a 4-arm study randomizing patients to ADT plus chemotherapy to treatment with either ABIRATERONE, and then randomizes them to receive radiation or no local therapy. So this is definitely something to look forward to in the future. I have no doubt that surgery will have a role in some of these patients, and we just need to wait for the data to see exactly what benefit it gives these patients. So what is expected in the future for metastatic hormone-sensitive prostate cancer patients? There are multiple ongoing trials assessing the combination of systemic therapies and novel medications in the metastatic hormone-sensitive prostate cancer space. The PEACE-1, as I said, this is the big 4-arm trial, standard of care versus standard of care plus abiraterone, standard of care plus local radiotherapy, and standard of care with local radiotherapy and abiraterone. So this will be a very interesting study to see the results, because it's testing a lot of things here, both local therapy to the prostate and combination of abiraterone as well, to see how that pans out. There's also the STAMPEDE trial, which of course continues to grow, and there's more arms being added all the time. I'm not going to go over all these arms, but basically they're going to compare abiraterone plus enzalutamide, ADT plus metformin, estradiol, and there's other arms that are happening. The ARASENS trial is also a very interesting study. It just finished enrolling metastatic hormone-sensitive prostate cancer patients receiving ADT plus chemotherapy, plus or minus darolutamide, which is another androgen receptor antagonist. This is a very interesting trial as well, and we eagerly await its results. It's being conducted in over 300 sites in 23 countries, and hopefully we can see the results soon. And this will add potentially another agent that we can use for these patients. There's of course trials assessing other new medications, Orteronel, another SWOG trial, which is assessing this drug. This is a novel reversible CYP17 inhibitor with more specificity for these 17-12 layers than abiraterone, supposed to be more specific with less side effects. There's a TRIUMPH trial assessing a PARP inhibitor, the rucaparib. There's of course immunotherapy trials. You have to have immunotherapy trials today, assessing all these new drugs, ipilimumab and nivolumab in the setting of prostate cancer. There's of course novel drugs, monoclonal antibodies like cemiplimab, and a lot more to look forward to. So to summarize, there have been really a plethora of studies, as you can see, in recent years, significant advances made in this space, basically giving all the treatments that we used to give for CRPC at an earlier stage. We're going earlier and earlier in the disease spectrum, and this seems to be working and providing a very significant overall survival and cancer-specific survival advantage. This has been declared, the combination of these systemic therapies has been declared as the standard of care now. Just giving ADT, which some places might still do, is probably not standard. It's not considered standard of care anymore. And aside from the novel treatments constantly being added, there's a clear trend of using these available medications in earlier stages of the disease. This field is rapidly changing. with more treatment options becoming available almost on a yearly basis. And really, and as I mentioned this before, the next major challenge is basically to understand and strategize which of these available medications are right for which patient at which stage, and what combination is the right combination. I think that's the most important thing that we need to understand, because we have now so many options. We need to understand which one is better for our patients. And with that, I would like to thank you very much for your attention.
Well, thank you very much. Great talk. Thank you, Dr. Anand Goldberg. And we are now open to questions from the audience. You have a tab to put the questions if you like.
There is a question.
Based on the LATITUDE trial. So I'll read the question. Based on the LATITUDE trial, patients with high volume disease benefited the most of abiraterone despite NS, I don't know what that means, NS, with a better side effect profile when comparing to chemo. Which patients should receive chemo fit and rapid progression only? Any experience in the BSDA in these patients with PARP inhibitor? Yeah, so this is all very good questions. Again, I don't think there's an answer. This is a very good question. I don't know which medication to give to which patient. That's exactly one of the issues. I think that the data for, and it's not significant, thank you. I think the data for the chemotherapy in high burden disease is very compelling. What I try to do when I see a fit patient coming to the clinic who's got high burden disease, de novo metastatic disease, high burden, I usually try to give him chemotherapy first. I'm not saying that this is the right thing to do. I just think the sooner we get it, it will be easier, because I think the adverse effects of chemotherapy are more significant than anything else. And if we wait with the chemotherapy, that's my philosophical view on this. If we wait with the chemotherapy, he might be at a worse stage later on and might not be able to get the chemotherapy. So that's why I prefer to give it to him in the beginning, and later on give him something else. But again, this is not based on any level 1 evidence. And I think with abiraterone, that's definitely an option too. But as you said, it was not statistically significant. That's why I prefer to give the chemotherapy, which has been shown to be highly statistically significant, and later on I give them abiraterone or enzalutamide depending on the patient. I hope that answers your question.
Can I just make an appointment or another question, that during this COVID-19 pandemic phase, do you think this may change our practice in order not to do chemotherapy front and these kind of patients?
Yes, that is an excellent question. I think with the chemotherapy, with the COVID-19, I have asked the oncologist about this, because in my practice, I actually see all these patients and I give them all the medication. I give them enzalutamide, I give them abiraterone. The only thing I don't give is the chemotherapy. Then I send them to oncologists. And I know it's not the same everywhere in the US or in the world for sure. But now with COVID, you're absolutely right. We should try to bring these patients as less as possible to the hospital, to the clinic. And there's no doubt that now during the COVID, I at least try to push more the oral therapy and less the chemotherapy, because it just puts, first of all, the patient has to come to the hospital, which puts him at risk. And we do know that cancer patients are at a greater risk for COVID. And second thing, when they get chemotherapy, their immune system goes down, they go to have neutropenia, that puts them even at further risk. So I completely agree that during the COVID, I probably would reconsider trying to give them oral medication first and maybe later on chemotherapy. That's a very good point. In the UK, okay, Maria, in the UK, we get permission to give enzalutamide in hormone-sensitive setting. Less patients receiving docetaxel even with GCSF due to COVID. Yeah.
Due to COVID. Yeah,
exactly.
Also, maybe Dr. Quintela is a medical oncologist, can help us with this question, because we are urologists.
I have a little bit different opinion about this. I think that when we have good, as we always have to have good attention with these patients, I think that chemotherapy is not a really problem in this era. I know that this is not a very conventional position, but it's my position. In my department in Santa Maria, in the hospital Santa Maria, we give more than 100 treatments, chemotherapy treatments a day in the overall pathologies, and I think that since March we have 2 patients with a COVID infection complicated, and because of other comorbidities, not because of chemotherapy for sure. But I would like to put a question, if I may. When we look to the guidelines, there's no doubt that we should have some drug to ADT at this in this setting of patients. But I ask your opinion about most of these trials don't include the very old men, very old patients. Low volume disease, the value of all these drugs is not so well established. Consider that in the older patients, older men, 80s and so on, is it fair to give, for any reason, just ADT, for instance?
Yes. So we mentioned that as well. So I think that's absolutely a good point. I think that when you see, someone who is a little bit older with more comorbidities, who has very low volume disease, that's actually in the guideline. One of the options is actually to give him only ADT. That's not a mistake. And I think that's actually, if you think that he's going to have significant side effects, or his quality of life is going to be damaged by this medication, and the medication is not going to give him so much benefit, I absolutely agree that most likely he could be doing very well just with ADT. There's no doubt. I completely agree.
So Dr. Ricardo Fernandez has made the other question, the other part, that is, have you any experience with BRCA mutations in metastatic hormone-sensitive patients? And I would like to put some other question, that is, in this setting, when do you ask for genetic testing for biomarkers like mutations on the BRCA or other kind of mutation in prostate cancer patients?
So both according to the guidelines, at least the NCCN, and I think the European as well, maybe you can correct me about that, but any de novo metastatic patient gets sent for genetic analysis, both for germline mutations and somatic mutations. We do this for everyone. So that's pretty much standard of care now. I know not everyone does it, but that's pretty much what we should be doing. I think the European guidelines say exactly the same, if I'm not mistaken.
Yeah.
And do you have experience using sorry, Ricardo. Do you have any experience using PARP inhibitors?
Yeah, so also a very good question. I think that we have now the PROfound study, basically looking at olaparib versus enzalutamide and abiraterone, but this was in the castrate-resistant metastatic patients. I don't think we have data on hormone-sensitive prostate cancer patients yet, so I don't have experience. I don't know, maybe the oncologists, have been more experienced than me in this, but I've referred 1 or 2 patients that had BRCA mutations, and they started receiving olaparib. But hormone sensitive, I don't have experience with that.
So there are some rumors on the chat section saying that the next Stampede arm will be answering to our questions.
I think that's not a rumor. I think that's true. I think they're going to test olaparib with something. That's one of the arms that they planned on doing.
Yeah,
so it'll be interesting to see.
But can I ask you another question? In a simple way, what would you recommend to urologists managing metastatic hormone-sensitive patients in order to simplify choosing the step on medication, choosing what medication to what patient, like index patients? How would you summarize to urologists and medical oncologists?
That's an excellent question. Again, what I tell you now is my opinion, which is based on not a lot. So that's a disclosure. But again, I try, if it's a relatively young and fit patient with high burden metastatic disease, I try to give chemo first. And then I usually give him either ABI or ENZA, depending on his contraindications. I know a lot of the patients don't like the steroids that go with abiraterone, the side effects that come from steroid. And a lot of my patients, at least, have diabetes, and it's usually not well controlled. So I have a tendency to give them more enzalutamide. So that's what I try to do. If it's a low volume metastatic disease patient and he's young and fit, then usually I just start him with either ENZA or ABI, and I don't give him chemotherapy. And if it's a very old individual with, again, with low metastatic disease, then ADT, as we just said before, alone is an option as well. And if it's a very old gentleman with many comorbidities with a high burden metastatic disease, then again, I try not to give him chemotherapy just because of the side effects, and I try to give him either ABI or ENZA. I hope that helps. I don't know if that's pretty much my philosophy. I see the questions here. Would you change from ABI or ENZA to PARP based on genetic profile? Then that's exactly what hopefully the studies would tell us. Again, we don't have data on this on the hormone sensitive space, but hopefully there can be a study about this, checking to see which one is better. And I would have no problem changing it as long as it's proven to be better. So that's simply, we don't have data. That's an excellent question. We simply don't have data. The next question is, what do you have to say about quality of life data? ABI seems a little better. I agree. The data on the paper seems better. I have to say, again, this is based on my department's experience, which is, of course, very anecdotal. But we have not had any significant issues with enzalutamide, I have to tell you. I have not seen many patients with many side effects or anything. Maybe it's, of course, a selection bias. But we have had patients doing very well, both with abiraterone and both with enzalutamide. So again, I look at the contraindications. I look if there's any history of seizures, if there's any history of diabetes. And I basically choose and I make this a shared decision approach. I tell the patients all the options, and I pretty much ask him what he prefers as well, and we basically reach a solution together. Another question from Professor Ricardo Lau. If we do chemotherapy for high burden disease, ENZAMET does not show good results after chemo. So I can turn the patient to an in. Yes, so that day, when I saw that data, it surprised me. I can't really explain that. I don't know, Ricardo, if you can explain, because I don't know I have no explanation. I don't know, one of you guys might explain that to me. So again, if a chemo patient, high burden disease, and he does really well, I try not to give him enzalutamide. So I try to give him something else. But I don't really understand it. I don't know why this result was shown. And another thing is fatigue is usually a big problem with ENZA. Yeah, I know. I don't know. I've seen fatigue in everything. I don't think I can't say again. This is all anecdotal data, but my experience has been that the drug, when it's given to the right people, the side effect profile is pretty good for both medications. It's not bad. It's really not bad. I haven't had to change a medication due to fatigue. Give someone ABIRATERONE instead of ENZALUTAMIDE just because of fatigue or something like that. At least I haven't seen anything like that. I don't know what's your experience in this.
Maybe Dr. Quintela, you see a lot of patients with ENZA. I actually see, I think all the patients that I have doing ENZA, they have fatigue, they complain.
And ABIRATERONE though?
Not as much as.
Well, I have no way to give numbers about my experience. I just can say that it's not quite different from one or the other drug. I don't think.
I agree. That's exactly what I see as well. There's no big difference.
So this is an expert opinion, not mine. So mine is biased as well.
The consensus opinion.
Yeah.
So can I ask another question? Maybe what I heard you talk about treatment of metastatic sites and treatment of primary tumor. In our center, normally we do some kind of patients following the results from STAMPEDE and from ORAD. We treat patients with radiotherapy. And you also said that you think that prostatectomy is also an option. So why do you think we don't do it?
No, so we're currently not doing it yet, but I have my gut feeling, my intuition tells me that the SWOG trial, that is the American trial that is being now done, and I know it's recruiting very well. I have a feeling it's going to show that prostatectomy, again, this is based on nothing, but I have a feeling it's going to show prostatectomy again in low burden disease, because it makes the biological sense here is the same, I think. I know that radiation has additional beneficial effects like abscopal effect and all these things that we talked about. But again, when you reduce the tumor burden significantly, either by radiation or surgery, in a patient with a low burden metastatic disease, I think you are helping it in some way. We currently don't do surgery in these patients yet. We're doing radiation for a lot of these patients. Low burden metastatic disease, we do radiotherapy for these patients according to the STAMPEDE protocol. I'm hoping that we can do surgery for them as well. I'm a urologist, I'm a bit biased because I want to operate, but I'm hoping that the trial, the randomized trial, will show that there's a benefit for surgery as well. And another question, which percentage of mHSPCa patients do you believe we see in all prostate diagnoses? What? Sorry?
I'm sorry, it's not it's prostate cancer we diagnose.
Okay. We anticipating treatment when compared to say, I mean, we do not. What do you mean, Ricardo? I'm not sure I understood you.
So I mean that some years ago, I think we were not diagnosing metastatic hormone sensitive. We are just giving ADT, nothing else.
Correct.
So now basically we are doing ADT plus ABI, ENZA, APA, which means that eventually we are postponing something that we don't want to see, this mCRPCs. So I don't know, I'm just thinking about the natural history of the disease. And I don't know, just in terms of all the concept of treatment of prostate cancer. Eventually, I don't know, maybe Dr. Quintela can also have an opinion about this. But I believe that we are doing the same kind of treatments that we were doing before for a different type of, eventually, a different type of disease. So I don't know eventually which benefit we will have. That's my point. I don't know, I'm just thinking.
Yeah, I know, I understand, but you have to, you know, there's a few issues here. One is that a third of the patients have metastatic disease. That we know of. That's the data. A third of the patients with prostate cancer. I think that since PSA screening was initiated, I think we diagnosed more de novo metastatic patients. This fell down from the USPTF task force when PSA screening got cut off. And now there's a trend that we're actually seeing more metastatic patients because they're being diagnosed later on. So, and the data shows that if you treat them earlier, I know it's the same treatment, but if you treat them earlier, they live longer. So you can't argue with the data. Data is very compelling. It's level 1 evidence, randomized trials over and over again for all these medications. There's many trials now. We didn't speak about this at all, but giving in the neoadjuvant setting before surgery.
Exactly.
We're here at UPSTATE with apalutamide before radical prostatectomy. We give apalutamide for 6 months, and then we do surgery. Everything is going earlier and earlier. We see this not only in prostate cancer, we see this in bladder cancer. Pembrolizumab now giving for non-muscle invasive bladder. It's the same concept. So, these medications are going to be given at an earlier stage. There's no doubt. That's the future. That's where we're heading.
I think we will leave is the designation of metastatic sensitive prostate cancer, or castration sensitive, or hormone sensitive and castration resistant. I think this is the main thing. I think we will live in the next years to say, we will start saying metastatic high risk prostate cancer or something like that, and treat with everything we have, because the concept of metastatic resistant or sensitive to hormone will be a nonsense for the weapons that we have now.
Yeah, for sure. I see there's another question. How do you sell to a patient incontinence?
It's a provocation from our colleague from radiation oncology.
Yeah, I think the same way we sell it to a patient with no metastatic disease. I don't think there's a difference. I can contra-provocate. How do you sell proctitis and risk of bladder cancer to a patient who is going to get radiation? Same kind of provocation. So both, as we know, both radiation and prostatectomy right now, according to the data we have, they're quite similar oncologically. And of course, there's a different adverse event profile, but there's cons and pros in each treatment, and each patient eventually has to choose what he wants to do. I treat the patient with brachytherapy. Okay, very good.
So I have to tell that Maria works in UK, and she's with us today, and she's keen to have some kind of questions that we don't want to answer. So.
No, it's very good. It's very good questions. Very good. Yes.
You have another one. If surgery, can you see it?
Yeah, if surgery in this context shows overall survival benefit, and as you don't have comparison studies, which would you choose, surgery or radiotherapy? Because besides the abscopal effect, the rate of positive surgical margins and high-grade complications is much bigger than in localized prostate cancer. Well, we don't know that. That's an assumption. Again, we don't know that. Again, I think we're back to the same question. Surgery or radiotherapy, even in localized disease, we don't really know which is better, and we say that the data is the same. So I think this is the same dilemma, just moving from the localized space to the metastatic hormonal sensitive space. But again, in the SWAP trial, they're doing both radiotherapy and surgery. So they're doing both. So it'll be very interesting to see the data. If one is better than the other, then of course we need to choose the one that is better. And I do a joint clinic with a surgeon every week. I can only recommend the model. Very good. I completely agree. Yeah, completely agree. I think it's very important to work together with radiation oncologists. There's no doubt. I have a radiation oncologist that I work with him on a daily basis. We're in touch on pretty much all patients. We both see the prostate cancer patient always. He sees him and I see him, and we always make a mutual decision about the patient. And I do agree. That's also something that we had in Toronto in fellowship, Ricardo, if you remember. I think that's very important. There's no doubt.
Let's see. Dr. Quintela, do you have more questions? And Isaac?
No more questions for me.
I don't have. I had some questions here, but most of them were already answered, so I don't have any more questions. Some are still unanswered, like sequencing and something like that. But I think the discussion was on that point already. Very good.
Okay, so I think we are done today. Thank you very much for your participation. Thank you, Dr. Quintela. Thank you, Isaac. Thank you very much, Hanan. This is our last session of this prostate cancer talk. So I'd like to thank you, Hanan, Thenu, Adel, and Zach for participating, I have to say, for free with us. It's a pleasure. And I think all of us, we learned a lot from you. I hope next year or somewhere, I don't know when, we can do some other sessions, and we for sure will have you with us again. So I'm pleased to say that we have in all these sessions some hundreds, in all of them, of participants outside of almost 400 people, which is very rewarding for all of us that were here every month. So thank you very much. This is a time of the year that I'd like to wish you a Merry Christmas and a very, very nice 2021, hopefully better than this 2020. And we will see you again. Thank you very much, all of you. Thank you, KUF. Thank you, Academia KUF. And hope to see you soon. Thank you very much.
Thank you very much. Thank you very much.
Thank you. Thank you.
Thank you.